Inflammatory bowel disease (IBD) is a broad term that includes chronic remittent inflammatory conditions of the gastrointestinal tract. In fact, both acute and chronic gastroenteritis can cause bowel inflammation. Diagnosis of IBD is IBD, I for isolated. No single test can confirm colitis or Crohn's diagnosis. B. Basket. The diagnosis is based on a basket combination of clinical, laboratory tests, endoscopic and biopsy histological and imaging findings. D. Other diseases to be excluded. Infections can present similar to IBD with abdominal pain, diarrhea, and endoscopic histologic finding. For example, tuberculosis, other parasitic, fungal, bacterial ones can be infectious mimics. Non-infectious mimics like autoimmune diseases, vasculitis, intestinal ischemia, drug-induced colitis. For diagnosis in other diseases, for example, acute cholangitis, in the past we based on clinical fever, epigastric pain, and jaundice. In hepatitis B, blood test is used for diagnosis by demonstrating positive HBsAg. In peptic ulcer, we use endoscopy to diagnose by seeing an ulcer inside the stomach. In colon cancer, a biopsy with histology is needed to confirm a diagnosis, while in gallstone disease, radiological finding is enough in the diagnosis. Coming back to inflammatory bowel disease, the diagnosis of IBD is based on a combination of clinical, laboratory tests, endoscopic, biopsy, histological, and imaging findings. Clinical information are needed in demonstrating chronic remittent disease cause and to exclude autoimmune and drug by history. In the laboratory tests, to show inflammation and exclude infection. In endoscopy, we can see the bowel inflammation by vision and to exclude malignancy. With the help of biopsy, histological examination, chronic inflammation of bowel can be demonstrated and also its infection can be excluded. Last but not least, radiological imaging can help in showing bowel extent and to exclude bowel ischemia. Therefore, the diagnosis of IBD is based on a combination of findings. The inflammatory bowel disease is usually further divided into two subsets, the ulcerative colitis (UC) and Crohn's disease (CD). But why is that so? It is because there are differences in symptoms, disease cause, and treatments between the UC and CD. Ulcerative colitis is diagnosed by demonstrating characteristic features of symmetrical, continuous, circumferential, mucosal inflammation, while Crohn's disease is diagnosed by demonstrating asymmetrical, focal, skip lesions, transmural, or non-caseating granulomatous inflammation. UC can affect any part of the large intestine, while CD can affect any part of GI tract from the mouth to the anus. Sir Samuel Wilkes, in a case report written in 1859, was the first physician who used the term ulcerative colitis to describe a condition similar to what is understood as UC today. Crohn's disease was recognized as an entity separate from UC in 1932 with a publication by Crohn's BB. In 5 to 15% of IBD patients, endoscopic and histological assessments cannot distinguish between Crohn's and UC, and these patients are labeled as IBD unclassified, or if features are still undeterminate after colectomy, histology is assessed, described as intermittent colitis. Symptoms: also IBD in my memory. I. Inflammation, fever, weight loss. Bowel symptoms like abdominal pain, diarrhea, blood in stool, urgency. D. Distant. Patient may have extraintestinal manifestations. My memory is SEAL, S-E-A-L. S. Skin, aphthous mouth ulcers, erythema nodosum, pyoderma gangrenosum. E for eye, conjunctivitis, uveitis, episcleritis. A for arthritis, seronegative arthropathy, sacroiliitis, ankylosing spondylitis, acute arthropathy. L for liver. In Crohn's disease, because of its focal transmural characteristic, it can have complications like fistula, abscess, and stricture. IBD causes. A basket of factors may cause IBD, internal and external factors. A little over 100 gene loci have been identified in international collaborative studies associated with CD and are believed to interact closely with environmental and microbial factors. One possible cause is an immune system malfunction, when the immune system tries to fight off an invading virus or bacterium, an atypical immune response incorrectly to environmental triggers, which causes inflammation of GI tract. IBD treatment. The doctors may consider three aspects. IBD. I for intensity, mild, moderate, or severe. B. Bowel, to see where there is colitis, proctitis, pouchitis, small bowel involvement, fistulating, abscess, or perianal disease. D. Disease status, induction, maintenance, or refractory state. The IBD medications. I use the memoric Catacomb, C-A-T-A-C-O-M-B. C for corticosteroids. A. 5-ASA, aminosalicylic acids. T. Thiopurine. A. Antibiotics. C. Cyclosporine. O. Other advanced medical therapies like JAK inhibitors. M. Methotrexate. And B. Biologics. Look at the last 3 letters of the biologics, MAB, which stands for monoclonal antibodies. Monoclonal antibodies are laboratory-produced molecules engineered to serve as substitute antibodies that can restore, enhance, modify, or mimic the immune system's attack on cells they aren't want. According to the guidelines, probiotic therapy may have modest benefits in UC, but should not be used routinely. By contrast to ulcerative colitis, there is no evidence of any benefit in the current literature for these treatments in Crohn's disease. All IBD patients should be advised to eat a varied diet to meet energy and nutrition requirements, including dietary fiber. The guideline recommended that smokers in IBD should be encouraged to stop, as smokers in Crohn's disease have a higher risk of disease flare, a higher incidence of surgery, and a higher risk of post-operative recurrent disease. Long duration of disease increases the risk of developing IBD-associated colorectal cancer, with the risk starting to increase at about 10 years after diagnosis. Later studies have shown the cumulative incidence to be 1% at 10 years, 3% at 20 years, and 7% at 30 years. Therefore, BSG guideline recommended that IBD patients with colonic disease should be offered colonoscopy 8 years after symptom onset to screen for malignancy, to determine disease extent and decide on the frequency of ongoing surveillance. IBD follow-up tips for patients and doctors. I. Inflammation. Any recurrence? When was the last time? Any fever? Any inflamed skin, eye, joints? Blood tests before follow-up. B. For bowel symptoms. Any abdominal pain, abdominal mass, bowel movement per day, blood in stool, tenesmus. D. For drug. The compliance, the use of antidiarrheal, any other medications, drug over the counter, or the supplements. Any side effects. Recommendations for further reading. Basic. For the public, I suggest to go to the CDC website, What is Inflammatory Bowel Disease? For the moderate reading, I recommend a review of 4 practice guidelines of inflammatory bowel disease. It takes about 10 minutes to read. And for the advanced reading, one of the 4 guidelines, for example, British Society of Gastroenterology Consensus Guidelines. It has more than 100 pages. 10 tips. I try to link IBD words to diagnosis, symptoms, treatment, and follow-up tips. Inflammatory bowel disease is a broad term that includes chronic remittent inflammatory conditions of the GI tract. IBD diagnosis is IBD. No isolated test. A basket of findings include clinical, laboratory tests, endoscopic and biopsy, histological and imaging findings, as well as other diagnoses to be excluded. There are practical reasons in subdividing the disease into ulcerative colitis and Crohn's disease. IBD symptoms are also IBD, inflammatory and bowel symptoms, with extraintestinal features. My memoric is SEAL, S-E-A-L. A basket of factors may cause IBD, internal and external factors. Treatment considerations are IBD, intensity, bowel extent, and disease status. The memorics of the drug names, Catacomb, C-A-T-A-C-O-M-B. Follow-up tips for both patients and doctors are also IBD. These are the references I read for this video. Thank you.